You're welcome. You're welcome to today's show. Pure Gospel, you are welcome. You're welcome. You're welcome. How are you? How's work? Good. How's the weather? How's the weather over there? Good to know that. The weather here is been extremely warm. Very, very warm. Very, very warm. Very warm. All right, you're welcome. Thank you for all your support. Thank you for your continuous support. Thank you. Thank you for your continuous support. Thank you. My pleasure. Yes. All right. So, what topic would you like us to discuss on our next show? Any suggestion? Any suggestion? Topic? Any suggestion? Our next topic. Next topic. Any suggestion? Let's share the video. Let's share the link. Let's share the link. Thank you very much for sharing the link. Thank you. Thank you for sharing the link. Let's like. Let's share the link. Thank you. So what topic would you like us to, any suggestion regarding our next week or our next time show? Let's like the video. Let's like. All right. So we'll start straight away. Maybe till other people joins. Or would you like us to wait a little bit? Okay. All right. Okay, so today's we're gonna be talking about how we're going to manage aggression, how to manage patients with aggression and violence, how to manage them, managing aggression and violence in patients who are navigating mental health challenges. How do we do that? So let's define aggression. What is aggression? Aggression is an intentional action aimed at hurting another person, whether through physical force, verbal attacks, or social manipulation. It is a distinct from related concepts. So why aggression? Why does aggression happen? Aggression arises from biological, psychological, and environmental factors. So sometimes people will ask, oh, why is the person presenting with aggression? Why is the person not happy? Why is the person presenting with violence and aggression? So hormones, genetics, and brain regions, they can influence aggression impulsively. So if you want to define violence, violence is commonly understood as physical harm, but sociological research expand it to include structural and cultural forms of harm. This includes not only acts like murder, assault, or but also systematic conditions such as poverty, discrimination, and exclusion that can damage people's well-being over time. So why does aggression happens? So when people get present with aggression, why are they doing it? So, and also behavioral, learned behavior, cultural norms, and stress shape how aggression is expressed. Frustration can trigger aggression. A classic finding known as the frustration aggression can happen. So why does violence happens? Why? It is not just about individual cruelty, it is shaped by power, history, social hierarchy, and international structures. Groups such as migrant women, racial minorities, all that can make that happen. So, aggression. What do we look at in the first place when aggression? How do we recognize aggression? We know this person because we are discussing how to manage our patients who are navigating mental health challenges, how to manage aggression and violence. Yeah. How do we do that? How do we know that aggression is coming up? So the first thing is to recognize early signs. So the early signs, one has to be proactive. If you are working, you are in a setting, in a healthcare setting, one of the things that you have to do as a staff is for you to be extremely observant. You have to know when a patient is escalating in his mood, when a patient is frustrated, when a patient is just going all over the place. We have to know that. We have to recognize the early warning signs. With that early warning signs prevention, that is how you can manage that aggression. You will know, oh, I think this patient is about getting angry. I think something is wrong. I think this and that. You observe. Is one of the first way to do that is by observation. You are welcome, Ikechuku. Thank you for coming. You are welcome. Ivan, thank you for joining. Please share the link. Share the link. Thank you. So recognizing early signs, that is the first thing, because if you are not able to catch or recognize that early signs, then it can escalate. Aggression is easier to manage when you intervene before it escalates. So that is what I do most of the time. So I observe, I will know, oh, this patient is getting aroused, something is wrong. What can I do? What can I do? As soon as I notice that, I act immediately. So what do I do? You watch them, sometimes they can just be going up and down, pacing, restless. There are so many things. They'll be clench, sometimes they'll be clenching their feet. Sometimes they just want to be on their own. Sometimes they don't want to talk to anybody. Sometimes they will just be interfering, being manic, going around. So all these are the signs. You pick all these things because it will be happening and you'll be seeing them. So if you can't pick all these, then it will escalate. So you notice environmental triggers such as pain or confusion. You see all these. These are the signs. As soon as you see these signs, you have to act. Because if you don't act, it's going to escalate. So what do you do when how to act? So the first thing, when you look at the way the patient is presenting, let's say the patient is coming, is screaming, is shouting, is doing all that. What you have to do as a staff is for you to bring yourself down. You start with your tone. You have different people working with you. You have your colleagues around you. You bring down your tone. It's two ways. If the patient is ready to speak to you, if the patient is ready to dialogue with you, then you can do that. But if not, what you have to do is to get the attention of your other colleagues. So you activate your alarm because you always have alarm with you. You have alarm everywhere on the walls, everywhere, alarm, bedrooms, name it, alarm is everywhere. What is the alarm meant for? It is meant for safety. It is meant for you to raise an alarm. It's called a panic alarm. So you raise it. The alarms, it's got different function. The alarm that you will just activate, it will call just your team within where you are. There's an alarm where you raise everybody in the building, the whole unit is going to come. There's an alarm where you raise, maybe you're in the garden, you take the patient out, the building will hear. So the alarms, they got different functions and everybody has been trained. So when they hear the alarm, they know what is happening. If a patient is in need of a bedroom and they need something like a cup of tea or whatever, they can activate the alarm. And when they activate the alarm, you know they are just calling you to come and help them to do something. So it's different from, or they are in danger or whatever. So it's different from other alarms. So we know the sound. We have been trained that this sound is for this sound is what is happening. So let's say, for instance, a patient is in the communal area and the patient is being very restless and is going all over the place. What am I going to do is to call their patient and say, Mr. B, are you okay? You find out from the patient first, why is the patient frustrated? Why is it going up and down? Is there any way you can help the patient? Sometimes the patient will say, yes, Joyce, can you help me get a towel? Can you help me get some cup of tea? Can you do this? Can you do that? Sometimes you can get their attention like that. But sometimes they are just angry because maybe they are frustrated. They are not just happy. So with that, even when you are trying to talk to them, they can be on the high side and say, don't talk to me. Go and sit down there. Who are you? You are a woman. Don't talk to me. They'll just be going, they can be going on and on and on. So what you need to do as a staff is to still calm down. You've alerted your colleague, so your colleague will be there. Because when you are trying to de-escalate, so what you do, you always leave one person to speak to the patient. Because if you have too many people talking at the same time, it will even get the patient more confused. So one person does the leads. And as soon as one person opens his or her mouth, every other person keeps quiet. But while they keep quiet, they are at alert in case the patient wants to be physically aggressive. Yes. So with that, sometimes you can ask, you tell the patient, can I have a word with you? No, 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 Joyce, you stupid, you da, 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 da. Okay. Would you like to sit down here? So you give every options while you are verbally using your mouth, you're not using hands or anything. You are communicating. So communication is the biggest thing, one of the biggest way to manage patients in any mental health institution. You have to know how to speak. You have to know how to communicate with them. Verbally, non-verbally, you'll be a very good active listener. You must be actively listening to them so that you know what to do. So your tone and your body language, if you are coming like this, the person, especially if he's a man, you are coming, hey, what can I do for you? Hey, only that alone, you will get that punch. If you come with your body language, you come, yes, why are you disturbing? The patient will give it to you. If you come in that manner, the patient will give it to you. The patient will punch you. It will punch you. So you have to, your body language, it should not be threatening to the patient, because the patient is observing you as well, because the patient will be thinking, is this person coming to attack me or grab me? Yeah, Ikechuku, this kind of job requires someone who is ready to bear aggressive words from those patients. So let me put it this way. We have what they call touch with reality. It means as I'm talking now, I am making sense. I'm able to think right. I'm able to do the right thing. I'm able to communicate. I'm able to understand you. I'm able to retain information. I'm able to give you feedback. I'm able to do all this. So imagine a word, WOLD, the word, that a person doesn't have the capability to do that. And this same person is angry. Maybe because of cup of tea, maybe because he's just hungry. So how should you react to such person? So that is where the training comes in. So as a psychiatric nurse or anybody that works with patients who are navigating mental health challenges, you go through series of trainings. Different trainings. We have what they call prevention and management of aggression and violence. You go through that training. How do you manage such patients? You go through communication training. You go through different types of training. You go for updates all the time, verbal de-escalation, how you de-escalate patients. So you go through these trainings. Still, you are still a human being. I understand that. But with those trainings, you'll be able to work with them. But if you know you are somebody, even when you have been trained, Ikechuka, I'm answering your question. Even when you have been trained, your statement, even when you have been trained and you still cannot do that, then you don't do the job. Don't go do the job, because you might end up getting yourself hurt, or the person might end up being laid off the job, because they have put rules and regulations, they have put guidelines, they have put those training in place for you. It is for you to follow that pattern, because in those settings, you are never alone. You have different response. We have what they call response team. Response team, they are the team, when they hear that alarm, they come straight to you. Wherever you are, they come straight. We have people who are in charge of the building. That's part of my job. I do it sometimes. So I will be in charge of a unit. So it means I have an alarm, I have a special phone. It's like on a kind of a call nurses. So when they activate, you are there. So you have this team ready. They are there to support you. So all these things are put in place. But if you know you are somebody that cannot manage it, it is better you don't go for the job at all, because you're going to read the job description in the first place before you go for the job. Yes, any question? Any questions so far? So we are discussing how to manage patients. We have talked about the early warning signs. Yes. So, like I've been saying, so you have to know if it's something you want to do. So if you know, it's just like you see the police, the armed forces, all of them, they've been trained. They've been trained, but they are human. They've got emotions. But we deal with people who sometimes don't have touch reality. It means you have to look for ways to look after them until they come back to themselves. You can see that can be challenging. So that's why these trainings, all the trainings, they've been put in place. And that is why with the job, sometimes you don't have to work. They give you time to go and rest because of what the job entails. So you can say to the patient, you say all that to the patient, you keep your voice low. So that's part of the communication training we need to, which is the way you are explaining this. You have mastered it very well. I've been doing it for a while. You are human in the first place. But at the same time, there are times you might not even want to remember those trainings. So what you do, what I do is, when I know a patient is escalating and I know I'm not in that mood to be able to control the situation, I don't lead. So when I go there, I keep quiet. I listen to what one person or whoever is taking charge, whatever they are saying. But because of my position, so what I do, even when they finish talking, I still have to intrude sometimes. Intrude when I'm maybe more calmer. Because if I go with, they're going to give it to me. Yeah. So you apply what we call, so after all that, you do what they call verbal de-escalation. What you're actually doing, you are using your mouth to say, sit down, can I help you? What's the matter? Calm down. Would you like to go to the clinic bedroom to relax? Would you like to go to the garden? So you are doing all this, you are de-escalating the situation. And verbal de-escalation is the best method to continue to employ. If not, by now you would have seen all this, my body, maybe one hand like this, one da. This mouth, you need it in the mental health setting. You need to actually know how to verbally de-escalate situation. Restraint is the last option. So you always use the least restrictive method. The least restrictive techniques, which is this mouth, verbal de-escalation. Sometimes you see me, I'll be doing to patient like this, please, I beg. It's okay. Say, Joyce, you started again. I beg. I don't have power to touch you today. I beg, please. What can I do for you? You see me doing all that. What am I trying to do? Especially a patient that I know can still talk to me, communicate. Yeah, any question? Any question? All right. So you do it. It's a technique. You do it. You use every technique to make sure you calm the situation. Because you go to work today, you're going to be doing both with patients. You can't do that job. So you actually need to be trained talking, communicating. Put yourself like this. When they see you like that, say, this one cannot even do anything. So it has nothing to do with the gender. They can attack a female, they can attack a male. Nothing to do with gender. It all depends on how you go, you do things with them. You see me sometimes, I'll just be playing with them, just be playing. They'll be looking at me. I'm serious, you are playing. I say, what do you want me to do? I beg, please. Sometimes I will ask them, do you understand pidgin? By now you should understand my pidgin. Should I use pidgin for you? So you have to use every technique. Sometimes when they see you like that, they'll say, Joyce, you started. Joyce, is because of you. Joyce, is because of you. You have to use all that. Even if you've been trained, you have to come to the patient's level. That is why you are doing the job. You have to come to the patient's level. Even if it's for you to sit down on the floor just to get things going, you do it. You do it. Because this is a patient that is not well. So verbal de-escalation, use active listening, because the patient sometimes, he will say, you are not listening to me. Oh, I'm not sure you are even listening to what I'm saying. You will say, please, I am listening. So what you will do, when the patient is saying something, you say it back to the patient. You say, I'm not listening. You say you want towel. Is that not what you said? The patient will say, hey, yes, I want towel. So you say it back so that the patient will know you are actively listening. Because sometimes someone says, hey, I can hear you. What is it? You started again. That you're doing all that, you'll get it. And another thing is, if a patient is coming with a forceful aggression, all you have to do is to break away, run away like you break. Don't go and do macho man. Oh, yes, come. No, you break away from the situation. You have to do that. You break away from the situation. Your alarm has been activated, because a patient can get more than 10 people running the whole place if they want to do it. If you meet people who are karate trained, chokwando, those ones. So you have to, but just like a melt, you melt yourself down. When they see you like that, they'll just calm down. They'll be looking at you. Miss, can you hear me? You say, yes, I can hear you. All right. You offer simple choices, like I said. What can I do? Do you want to go here? Do you want to do this? Do you want to do that? Pure gospel, any mistake via words can bring. You have to use your tongue, soft. Not the way I'm talking now. When you are with them, if they are very angry, frustrated, they will be on top of their voice. It means you have to calm yourself down. That is why you have to recognize the early signs. The signs are always there. It's only on a very few occasions when you have what they call impulsive behavior. So they will just come like that, boom. So that's impulsive. The people that present in that manner, is two ways they present in that manner. One, they might be hearing voices, and the voices is telling them to hit you, that you are the one fighting them. And they will do it because the voices are telling them to do it. So when they are hallucinating, that's one. Two, when they are hallucinating, they can just do it. Two, when they see you the way you are coming, they can do it. So you don't argue with them. No. You want to correct them in that situation. No, you don't do that. Or you'll be matching emotions, because, like the male gender, they are more of, especially depending who you're working with, whether it's male, whether it's female, or both. So you prioritize safety for everyone, high risk. When aggression escalates, safety becomes the primary focus. You position yourself near an exit and avoid being conned. You've called for assistance, you've done all that. Always follow your organization protocols for your alarms, for your security or restraints. You must follow it. If you don't follow it, and they vex too much. Please share the link. Give a thumbs up. I've only got 2 likes here. More likes, more likes, more likes, more likes, please. Only 2 likes. More like, more like. Share the link, please. Thank you. Any question? Any question? More likes. More likes, please. So, like I said, you must follow your trust protocols, how you have been trained, how you are supposed to do it, follow the techniques, follow everything. Then you will ask me, in this situation, how will I really follow how I'm supposed to place my hand, do this, figure 1, figure 2, place the hand, hold on. How am I going to do all that? When you are really, 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 you are rose. The patient has made you to be angry. You're just going. So what we do, we move you away. You don't join whatever we are doing. We just like push you as if we push you aside. Because in that situation, we have to. There are some situations we have to like jump in and do what we're supposed to do. You jump in. So even when you jump in, you still start with verbal de-escalation and ask the patient what is happening, what can I do for you? Then before you now start, you want to give the patient medication. But the first instant is verbal de-escalation. Use your mouth. Then what you now do is for you to tell the patient, I'm going to medicate you. I'm going to give you some medication. And you tell the patient, it's 2 ways. That is, if the patient is catatonic, that means the patient is not talking and all that. So you have to use what you think is best for the patient. You use the verbal escalation. Try to use your hands. Okay, patient, have a seat. This is what I want to do. I want to give you medication. You still be speaking to calm you down. So the patient can just be using his head, demonstrating, is telling you, no, don't touch me and all that. So you have to medicate. You go for oral medication first. You give oral. It can be liquid, it can be tablet. Sometimes the patient will take it and say, when you give them, they will take it. Then when you try, or sometimes when you try to give it to them, they are still saying, no. So what you do, you speak to the patient again. I am going to give you an injection, which is called intramuscular injection, IM. And these are the medications I want to give to you. And the reason why I'm giving it to you is because your mood, you've been very angry and all that. You've been aggressive and things like that. You explain. You still be doing it and you explain. So you do it. So there are some situations the patient will say, okay, give me injection or give me tablet. It goes like that. Sometimes it doesn't happen that way. Intramuscular injection is a heavy drug one. No, we have what they call benzodiazepine. It's a group of medication which you take, which I take. So you've heard of volume 5. In Nigeria, you guys call it, we call it volume 5. You know, there are some medication that will just calm you down. So if you take tablet, you have some tablet, the benzos, you have what they call lorazepam. You have what they call clonazepam. I'll use these 2 to give you an example. So those volume you take is part of the group. Yeah, just like they give it to us to relax us. So it's the same thing. So when you take something, when a patient is very aggressive and all that, you go, if it's tablet you are going for first, you go for what they call lorazepam. So it's a group, is under what they call the benzodiazepine. So when you take that lorazepam, it works faster. Even if it's tablet, it works faster than what they call clonazepam. Clonazepam works, but is a slow-acting medication tablet. So it is slowly. So if you give a patient that is very manic, it can take 4 or 5 hours. The patient will just be in a very low pace. Yeah. Then when you know the patient doesn't want tablets or liquid, you go for the IM. What the IM does, it goes straight to the bloodstream, so it works very fast. Very fast. So With that, within few minutes, within 31 within it start working. So what you are trying to achieve something, you trying to make sure the patient calms down. So once you do that, you have what they call rapid, because it's a rapid tranquilization. So rapid tranquilization has a protocol as well. So you have to follow that protocol. The protocol is that once you administer IM injection, yeah, once you administer it, you have to follow that protocol. The protocol is that as soon as you do it, you start monitoring the patient vital signs. You have a team. It's not just you. You might have 10 people there with you. You might have 12. You might have 6. You have like a team, people with you. You have senior nurses. You have doctors around. You have a team. So you are not just on your own. So somebody else will be doing the vitals. So it's two ways. Sometimes patient will tell you, I don't want to do vitals. Leave me alone. Da, 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 like that. So what you do, you monitor the patient's activities. What is the patient doing? Is he still walking around? Is he alert? Is he sitting? My question, what about after explaining to the patient politely that you want to give him or her medication and the patient refuses to listen to you? What do you do? Good. So what you do is that two ways as well. You know, some patients, when you tell them you want to give them medication, they will just calm down. They will say, no, no, miss, I'm okay, I'm okay. You will not ask the patient, what can I do for you? Would you like to spend some time in a quiet place? The patient will say, yes. You allow the patient to go. So when the patient says, no, 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 and the patient is still angry and all that, and is refusing to take oral, you give intramuscular injection. You give it because you can see the way the patient is presenting, the way the patient is going or behaving. You need to calm that situation down. But there are times you don't need to give them any form of medication and they will be fine. Yeah, they will be fine. They will tell you they will be fine. So you are observing, the team is observing, everybody's observing. So they will just tell, I want to go to the garden to relax, and they will be fine. You just go there. When you see them, sometimes they will tell you, can I have a staff to sit with me? You sit down with them, you have a chat. They're not going to touch you or anything. You sit with them, they will now start talking to you why they are angry, this, that, that, that. They will talk to you. So a different situation, different situation. It all depends on what is happening. So not all the time you have to do all that. So there are times you have to physically restrain the patient. You restrain them. It all depends on the situation, what is happening. You go for restraint. As soon as you see them, you are talking, you're not getting any headway, you restrain. We have been trained to restrain. So we restrain. We follow the trust protocol and do a restraint. So under that restraint, we can make the patient to sit down. We can make the patient will sit. We can take the patient anywhere. We can move the patient by ourselves. So we can do all the kind of maneuvers we want to do, and we make the patient to actually sit. So even if the patient does not want to sit down, we can do it, the patient will sit. So it's a form of restraint. We restrain them to sit. We restrain them to make sure we keep them safe. We keep everybody safe. So we do all that. So we can do it. Even if the patient does not want to sit, we forcefully make them to sit. So it's a form of way to restrain them as well. So while they are seated, one person will be in front and be talking to them. Sometimes it even takes us a while to do medication. We want to de-escalate the situation verbally. So we'll still be talking. Other people are holding the patient. The patient is seated. So, and we'll still be talking. So if we are able to verbally de-escalate that situation, even in that restraint, we don't go further. We don't do medication. We just, when we are doing it, we'll be talking to the patient. We are talking. We'll still be talking. We'll still be talking. We continuously be talking to the patients. So we can have that without nothing. There's some with medication. Even after giving medication, you put the patient under restraint. We have what they call pod. There's a pod where we have to restrain the patient and do the injection. While we are there, we'll still be speaking to the patient. We'll still be communicating. You know why we are restraining you now. These are the reasons. We leave you now. Are you okay now? Have you calmed down? All right. We'll still do all that. We still de-escalate. We still leave the patient alone. We still go out of the restraint. Sometimes we can restrain patient, all depends on what is happening. And when one person is like holding the hands, doing the legs and all that, the head and all that. So what you do, we do exchange. We've been trained how to exchange. During that exchange time, the patient can start struggling again, but we are doing it. So yeah, so any questions? Any question? Any questions? So I'm going to do maybe a video or something of restraint and all that, so that people will understand restraints. People will understand properly verbal de-escalation. I might do a show like this. So I would like to get people's view and all that. What do they think? Because people always feel, oh, hey, this job, they're going to break my head. They're going to kill me. They're going to do that. No, people have been trained. Most times it's when you don't follow those protocols. I had a time, a staff came, no, let's go and restrain. I can't wait. Let's go and restrain. Let's go and restrain. Let's go and restrain. I said, who are you restraining? Who is going to help you? That's why I told the staff. I said, do you think I want to restrain? I don't want to restrain. I want to use my mouth. So the staff was just rushing. I said, look, I don't rush. I've been trained to use my mouth and it works. Before I will restrain, it will be difficult. If you're using your mouth, it can take you 1 hour. It can take you 1 hour, 30 minutes. I don't mind doing it. It can take you 30 minutes, so it depends. Than me just going for restraint or injector. No. No, it's not a good practice, but we have to do it for safety if we have to do it. But it should be our last resort. And we have to use the least restrictive method, which is this, verbal de-escalation. Okay, yes, my dear, it's a question I just asked now. It should be the last option. Yes, it is the last option. Any question? So, when you have restrained a patient, you have given them injection, you have done everything you want to do, what do you do as a staff? You still have to support them. After that, we have to do what they call a debrief. We debrief the patient, we tell the patient what we have done and why we did it, and ask the patient, do you have any injury? Would you like to see a doctor? We still ask. Sometimes patient will not answer us. If we know there's injury, we call the patient, the doctor to come and see the patient and tell the doctor what has happened. So after that, we do a debrief within ourselves as staff and ask first any injury. So it's 2 ways again. Yes, there's no injury. Okay, how should we have done what we did? What would we have done better? So people will be bringing their suggestion. People will be saying this, saying that, saying that, saying that. And let's say you ask, is there any injury? Yes. What and where and where? You will not say it. We get a doctor to come and see you as a staff. If it's something, the doctor can say, okay, we want to send you to another hospital so that they can check you. We'll do that. Then during the restraint, the maneuvers, the techniques, you see the techniques, all those stuff might not go well at all. Some people might lose their holds. It means if you're supposed to hold a patient like this, you lose it. So when you lose it, the staff will be injured during that period. As soon as you lose any holds, it's called HOLDS, holds. You know, when you hold somebody, you're supposed to hold that person so that the person don't leave that position. So by the time you lose your holds or you are struggling with the techniques, there will be injury. 100%. If somebody does not chip in quickly, if you don't do the techniques properly, you will get injured. It might be minor, it might be a serious one. So it all depends. Sometimes we get minor injuries, sometimes we get serious injuries. Yeah. So we do get that. So sleeping pills, then you apply the injection. No, you don't call it sleeping pills. Sleeping pills are completely different from um, benzodiazepine. That's one thing that helps calm the nerves. And when it calms the nerves, it makes you get some rest, but you actually have medications that are called sleeping tablets, like melatonin, like Zoplicon, all this one. Then, when somebody wants to do an operation, all this kind of medication, those ones are different. So if you give me a Zoplicon, I will it that's a proper sleeping tablet. It's meant for me to actually sleep, sleep, sleep. You can give somebody clonazepam, which is among the benzo or lorazepam. They will not sleep, but it will slow their actions. Just slow them, slow them. They are fine. They'll be doing whatever they are doing, but they will not. You will not see that aggression. You won't see it. To just slow them for that time. So, but if it's sleeping tablet, it means you give it to me and fall asleep straight away. But those tablets, those benzos, can make them calm their nerves and make them sleep, but not say it's called a sleeping tablet. No. Like one other one that we call promethazine. Promethazine is an antihistamine. It means if you got allergy, whatever, you can take it. That can also help you calm down as well. So I can take it if I'm having allergy and all that. If my body is not too strong or whatever, I can get some rest with that as well. Just like you have cough and all that, there are some medication that will make you, they have some that is called drowsy, the one that is not drowsy. So it all depends. Yeah. So once it has happened, you support the patients, you speak to the patients, you do a debrief, you say why, how long does it take those patients to recover fully? Yes, it all depends on, that's a pure gospel. It all depends on what is happening to the patients. And first, presentation means if it's the first time a person becomes mentally unwell, it is quick for them to get better. They can get better within few weeks, 1 month, they are fine and they can go home. But when you have recurring relapse, so your body will not be used to so much all those medications. For sometimes the medication will stop working. So when we are treating you, it will take a longer time. Sometimes your body will not just go with the medication. Pardon me, your body will not just go with the medications, and it will take a longer time as well. So it all depends on your body makeup, and how long you've been in the system, your reoccurrence. Because the more you relapse, the more it takes longer for you to get better. Then, if it's just for during that restraint, maybe within 2-3 hours, everything is fine. Sometimes an hour, sometimes 30 minutes, the patient is fine and all that. You have to reassure the patients. You have to make sure you know this trigger, what caused it. Um, so your what you do after the incident, you debrief, you tell the patient what has happened, you reassure the patient, you know why it has happened. The patient, you will see the patient sometimes can tell you, most time they tell you, then you reinforce boundary, this behavior is not acceptable and all that. So you do all that. You do what they call incident reports. Any incident that happens, whether it's the one that has happened or near miss, you must document it. We have a template. Every unit has a template where you document incident. You must document incident. You let the police know. You do all that. You do all that. So you have to follow those protocols. Anything that happens, if you mistakenly hurt the patient, everything you have to do it. So it's part of the job. You don't hide anything because you might be restraining. As you are restraining, you might be 10 there, 15 there, 12 there, 11, 6 or whatever. You'll be restraining. And during that time, you go home. While you are restraining, you feel nothing has happened. But after the restraint, it can be 1 day, 2 days, something might have happened and you wouldn't know, either to the patient or to yourself. So those documentation helps you a lot. So you might have somebody who restrained today, 2 days time, the leg is swollen, the hand is swollen, the eye is swollen. You see some immediately, you don't see some immediately, especially if it affected the bones. You might have a dislocation and you see the place getting swollen. Yeah. So then you can be cared for, or the patient will be cared for. So any question before we close? So thank you so much. Always review. Yeah, so thank you. Any question? I've only got 3 likes. 3 likes. So thank you for joining today. We might be doing some changes regarding this live shows. So we're going to update everyone the time or the day that we're going to do it, or how often we're going to do it, and the method we're going to use. We want it to be more interactive. And yeah, so we're going to inform everyone regarding that, and we're going to pass on messages just for everybody to know what changes we want to make regarding the show. We want it more interactive, and we want more people to join. I know we are doing it at 2. At 2 is like you breaking in between people's job and all that. So looking for a more convenient day, more convenient time, which is very important for everybody, because most people that like joining shows, they want to be back from work. They want to be sometimes during the weekend, sometimes when people are always off. Yeah, so this show is because we just started, although we are like almost 3 months now. So we're trying to experiment some stuff, which we think we've experimented enough for this time. So that's why. Yeah, so we'll be doing some changes and we'll be passing across the messages. Thank you so much, Stress Village people. Even, no. Uh, not at all, not at all. It's just for us to understand. This is called knowledge. Knowledge. That's why we say it's called knowledge. Yeah, but the thing is safety first. So if you as a staff cannot manage the aggression, somebody else needs to do it. Somebody in that group needs to do it. So yeah. So we're gonna leave now. Yeah, thank you so much all for joining. Thank you, and bye-bye. We the future, confidence in action. Thank you. Bye-bye.